Welcome to the deep dive. Today we're looking at hyperbaric oxygen therapy, HbO2. It's this treatment where you breathe pure oxygen, pressurized, and it seems to hold real promise for healing.
It really does. But like anything powerful, there can be downsides.
Exactly, and we're focusing on one specific risk today,
Yeah.
oxygen toxicity. Now, I should say, the good news is that HbO2, when it's administered correctly, with the right protocols based on solid science, it's generally considered very safe and effective.
Absolutely. It really comes down to understanding the balance we're manipulating when we introduce these higher oxygen levels.
Right.
So our mission today really is to unpack the science of oxygen toxicity. What is it? What's happening inside the body? How does it, manifest? And crucially, how is it managed and prevented in those hyperbaric settings?
Yeah, let's shine a light on the body's own defenses, those antioxidant systems, and also the safety measures used in HbO2 to guard against, oxygen poisoning. Okay, so where do we start unpacking this biochemically?
I think that's the best place. So think about oxygen reduction in the body. As oxygen molecules take on electrons, sometimes sort of step by step, they can form these unstable, highly reactive molecules. We call them reactive oxygen species, or ROS.
ROS.
Key ones you hear about are superoxide, hydrogen peroxide, and then the really reactive one, the hydroxyl radical.
So these ROS, they're the troublemakers we need to watch out for in this context. What kind of damage can they actually, do?
They can cause a whole cascade of issues at the cellular level. A big target is the cell membrane. These radicals can sort of kickstart a chain reaction called lipid peroxidation.
Lipid peroxidation
Yeah.
sounds like damage to the fats in the membrane.
Exactly. It degrades the structure, but they can also directly attack proteins, changing their shape, messing up their function, and even deactivate critical enzymes that our cells rely on.
Wow. That sounds like a recipe for cellular chaos.
Well,
How does the body normally handle this kind of thing, just breathing normal air?
that's where our built-in antioxidant defense network is key. We have specialized enzymes working constantly. Think superoxide dismutase, catalase, glutathione peroxidase, glutathione reductase.
The whole enzyme cleanup crew.
Pretty much like a microscopic security force, as you said. And it's not just enzymes. We also rely on antioxidant compounds, things like glutathione itself, selenium, vitamin E, vitamin C, they all pitch in.
So it's a team effort.
It really is. And whether oxygen toxicity actually becomes a problem depends entirely on this balance. How fast are those reactive species being made versus how quickly can our antioxidants neutralize them?
That makes sense. Understanding that balance must be key for HbO2 protocols?
Precisely. It helps explain why certain pressures, durations, and even individual factors influence the risk.
Now, I saw in the sources mention of specific agents studied to actually delay seizures linked to oxygen toxicity. That sounds really interesting.
Yes, that's an active area. Researchers have looked at compounds that seem to interfere with the process leading to CNS oxygen toxicity. For example, diethylic carbamic acid and 1-aminobenzotriazole. These are antioxidants that seem to target certain enzymes involved in making ROS, and they tend to build up in brain tissue, offering sort of targeted protection there.
So by reducing ROS production specifically in the brain, they might push back seizure onset.
That's the idea. Then you have things like the 21-aminosteroid compounds, sometimes called laseroids.
Laseroids.
Yeah, they're thought to work by binding to free iron, which can act as a catalyst in that damaging chain reaction in nerve cell membranes.
What else?
Propranolol, which is a common beta blocker, has shown some protective effects too, maybe by reducing overall brain activity and blood flow.
Interesting.
And even low doses of caffeine have been seen to delay seizures, perhaps through effects on brain blood vessels and its own antioxidant properties. It just shows how complex these interactions are.
Caffeine. It keeps popping up. And there was also something about heat shock protein 27. Sounds quite cutting edge.
It is. It's still under investigation, but the thinking is that heat shock protein 27 might help regulate the production of reactive oxygen species by certain other proteins. A specific form of it seems potentially protective against oxidative stress. So another potential avenue for future research.
Okay, fascinating stuff on the biochemical side. Let's shift gears now. What happens when oxygen toxicity actually shows up? The sources break it down by CNS, pulmonary, and ocular effects. Let's start with the central nervous system, the CNS.
Right. CNS oxygen toxicity is definitely a major concern, particularly at pressures over 2.0 atmospheres absolute, or ATA. The most dramatic manifestation is a grand malconvulsion, a seizure.
A seizure. That sounds really serious. Does it usually come out of the blue, or are there warning signs?
Thankfully, there often are premonitory symptoms, though not always. The sources list quite a few potential signs.
Like what?
Things like facial pallor, going pale, an odd breathing pattern where you're inhaling more strongly, sweating, sometimes spasms in the diaphragm, changes in heart rate like slowing down or palpitation, nausea, even sudden vomiting. Neurologically, you might see twitching, especially around the lips or eyelids, tunnel vision, ringing in the ears.
Menitis.
Right. Even things like auditory hallucinations or vertigo, that feeling of spinning. It's a wide range, which really highlights why close monitoring during HbO2 is so vital.
Absolutely. So if a clinician sees any of these signs during a treatment, what's the immediate plan?
First thing, immediately switch the patient off pure oxygen onto breathing the regular chamber air. If the symptoms clear up while breathing air, that's a strong indicator it was oxygen toxicity.
And then what? Stop the therapy.
Well, once the patient is fully recovered with no lingering neurological signs, resuming HbO2 might be possible, but you'd absolutely need to adjust the protocol. Maybe add more air breaks, perhaps reduce the pressure slightly.
Okay.
The key thing is, if injury is avoided during the seizure itself, there usually aren't any lasting neurological problems from an oxygen-induced seizure.
That's very reassuring. Okay, let's move to the lungs. Pulmonary effects. I mean, breathing high-pressure oxygen for long periods can't be great for the lungs, right?
That's correct. Prolonged exposure, especially at oxygen pressures above half an atmosphere, 0.5 ATA, can start to irritate the lining of the windpipe and bronchial tubes.
What would that feel like?
Patients might describe a burning feeling behind the sternum, chest tightness, maybe a cough, shortness of breath.
And if the exposure continues?
It can progress to something much more serious. Acute respiratory distress syndrome, or ARDS.
ARDS, yeah. That's serious lung injury. What's happening physiologically then?
You get damage to the endothelial cells lining the tiny blood vessels in the lungs. This makes them leaky. Fluid starts seeping into the lung tissue and air sacs.
Pulmonary edema?
Exactly. Pulmonary edema, protein buildup, inflammation. It can ultimately lead to respiratory failure. Now, this typically develops more gradually at lower oxygen pressures, but can happen faster as the pressure goes up.
But can the lungs recover?
Yes, the good news is that the early signs of pulmonary toxicity usually reverse once the high oxygen exposure stops. And standard HbO2 treatment protocols, like the ones in our sources, are specifically designed to stay well within safe limits to minimize this risk.
Okay, but how do doctors actually track or quantify that risk for different treatment plans? That's where this UPTD thing comes in, unit pulmonary toxic dose.
Precisely. UPTD is an attempt to put a number on the potential lung toxicity of a given oxygen exposure. It basically standardizes the dose, expressing it as equivalent minutes of breathing 100% oxygen at sea level pressure, 1.0 ATA.
So it lets you compare different protocols, like treatment A has a higher UPTD than treatment B.
Exactly. It helps clinicians estimate the potential pulmonary impact and choose safer regimens.
The sources had a table with UPTD values for common protocols for bone infections, CO poisoning, various Navy tables.
Right. So UPTD value gives you a rough idea of the expected effect, often measured as a small, temporary decrease in lung capacity. But it's crucial to remember these are guidelines, often based on studies in healthy young men.
So individual responses can vary.
Definitely. And while you can add up UPTDs over multiple treatments for a cumulative dose, that doesn't perfectly capture the lung's ability to repair itself between sessions. Still, it's a very useful risk assessment tool.
It was interesting, though, that the sources noted patients often tolerate quite high cumulative UPTDs over many daily treatments without major problems. Shows the body's resilience, maybe.
It does suggest a degree of adaptation or repair capacity. It reinforces that these are guidelines, not absolute hard limits for everyone.
Okay, let's turn to the eyes. What are the potential ocular effects of HbO2?
One of the more commonly reported effects, especially with longer courses of daily treatment, say 90 to 120 minutes at 2.0 to 2.4 ATA for chronic issues, is progressive myopia. Nearsightedness.
Nearsightedness. How common is that?
The incidence is reported somewhere in the range of 20 to 40%. There's maybe some suggestion it's more common in older individuals or those with diabetes.
20 to 40% sounds pretty high. Is it permanent?
Thankfully, usually not. In the vast majority of cases, vision returns completely to normal within about 6 weeks or so after stopping the HbO2 therapy.
Okay.
But the sources do mention rare instances where the change was irreversible. The exact mechanism isn't perfectly understood, but it's thought to involve changes within the lens of the eye.
What about cataracts? Is that a risk?
The evidence suggests that really long courses of HbO2, think hundreds of treatments, might potentially speed up the progression of existing nuclear cataracts in some people, and maybe, extremely rarely, contribute to new ones forming.
But not with typical treatment courses.
Exactly. For the more standard 20 to 50 treatments used for most conditions, developing new cataracts isn't generally expected.
That's good to hear. Any other visual issues?
There have been other reversible effects seen, mostly in experimental conditions with very high pressures or super long exposures. Things like temporary narrowing of peripheral vision or changes in the electrical response of certain retinal cells, but again, generally well outside standard clinical practice.
Right. So for the eyes, effects are mostly temporary or linked to extreme protocols. Now, what about individual differences? It sounds like some people might just be more susceptible to oxygen toxicity than others.
Oh, absolutely. There's significant variability between individuals in how they tolerate high oxygen levels, affecting both lung and CNS toxicity, even varies across species. And susceptibility can definitely be influenced by things like pre-existing conditions, other treatments, medications.
Understanding those factors must be critical for safety.
It is, for tailoring treatment and managing risk.
I saw a mention that achieving ketosis, maybe using ketone esters, might help prevent oxygen seizures. That sounds like a really interesting link between metabolism and neuroprotection.
It's a fascinating line of research. The idea is that the metabolic state of ketosis, like with a ketogenic diet, seems to confer some protection on the CNS, making it more resistant to oxygen-induced seizures. So researchers are looking at whether giving specific ketone compounds could mimic that effect. And separately, there's work on saturated hydrogen saline. Hydrogen acts as an antioxidant, and some animal studies suggest it might help reduce lung injury linked to low oxygen states, which can also involve oxidative stress. So exploring both metabolic and direct antioxidant strategies.
Right. And then the sources provided these lists. Factors that can make oxygen toxicity worse or happen faster, and factors that can delay it or make it less severe. Quite a few things on those lists.
Yes, it highlights the complexity. Things that generally decrease oxygen tolerance include high levels of stress hormones like cortisol, increased CO2 levels, certain adrenergic drugs, stimulants like dextroamphetamine, fever, insulin, norepinephrine, hyperthyroidism. Even things like the herbicide paraquat, vitamin E deficiency, or starvation can make it worse.
Wow, that's a diverse list. What about factors that improve tolerance?
Factors that tend to delay onset or reduce severity include things like previous acclimatization to low oxygen, antioxidants in general, low-dose caffeine, as we mentioned, certain medications like chlorpromazine or GABA-related drugs, glutathione, hypothyroidism, propranolol again, succinate.
Okay.
Also, intermittent exposure, those air breaks we talked about, is huge. Hypothermia can help, but has its own risks. Disulfiram has shown mixed results. Vitamin E sufficiency is protective. It really paints a picture of how many systems are involved.
It really does. That list underscores the intricate physiological response. And that point about air breaks, alternating oxygen with normal air, seems fundamentally important for making longer treatments feasible.
Absolutely critical. It's a cornerstone technique. Early animal studies showed it worked, and human studies confirmed it's essential for extending tolerance, allowing for treatments that are both longer and ultimately more beneficial.
Okay, so we know the risks, we know factors that influence them, and we know about preventative measures like air breaks. What about actually managing an oxygen-induced seizure if one does happen during HbO2?
The absolute top priorities are patient safety. Protect them from physical injury inside the chamber, prevent aspiration inhaling fluids, and, critically, do not decompress the chamber during the active, rigid phase of the seizure.
Right, because the trapped gas expanding in the lungs could cause an embolism.
Exactly, a potentially fatal arterial gas embolism. Decompression should only start once the patient relaxes and starts breathing normally again.
Makes sense. Any environmental considerations in the chamber?
Yes, the oxygen delivery system, like a hood or mask, should be designed to minimize CO2 rebreathing. Elevated CO2 significantly lowers the seizure threshold, making seizures more likely even at lower oxygen pressures.
Why is that?
Because CO2 dilates blood vessels in the brain, increasing blood flow and thus delivering even more oxygen to the brain tissue.
Ah, okay. And what about people with epilepsy?
They are known to be more susceptible, so it's vital to ensure their regular anticonvulsant medication levels are adequate before they undergo HbO2.
So if someone does have an oxygen seizure during HbO2, does that mean no more treatments for them?
Not necessarily, no. These seizures are usually self-limiting, meaning they stop on their own, often without needing specific anti-seizure drugs right then and there.
Okay.
Having had one doesn't automatically rule out future HBO2. But, as we discussed, the treatment protocol absolutely must be reviewed and modified. Shorter oxygen periods, more frequent air breaks, maybe lower pressure. Prophylactic medication like diazepam might be considered for high-risk individuals, but starting new long-term anticonvulsants just because of one HBO2-induced seizure in someone without prior epilepsy isn't generally recommended.
Right, okay, this has been a really thorough deep dive. It seems clear that oxygen toxicity, while it's a real risk with hyperbaric oxygen therapy, it's a well-understood one, and it's actively managed through careful protocols, watching for those warning signs, understanding individual risk, and leveraging the body's own defenses.
Exactly. Our bodies have these amazing inherent antioxidant systems. By continuing to understand the complex dance between reactive oxygen species, these defenses, and all the factors influencing oxygen tolerance, we can keep refining the safety and maximizing the benefits of what is a really valuable medical therapy.
And that leads us perfectly into a final thought for you, the listener. We've talked a lot about reactive oxygen species in the context of oxygen toxicity, but these molecules also play fundamental roles in, aging and many chronic diseases. So consider this. What if strategies designed to boost our natural antioxidant defenses could offer a double benefit? Could they not only make hyperbaric oxygen therapy even safer, but also potentially contribute to better overall health, maybe even longevity? What areas of research do you think hold the most promise there? Definitely something fascinating to think about. Thanks for joining us for this deep dive.